Hi, everybody. Today we're going to be talking about eating disorders. We've probably seen a lot about this in, those movies of the week. In addition, many of us probably know individuals or ourselves have had some sort of disordered eating. So it's a topic that a lot of people can relate to on many levels. So there are six main eating disorders in the DSM. The bulimia nervosa, anorexia nervosa, so those are what we typically call bulimia and anorexia, binge eating disorder, pica, rumination disorder, and avoidant restricted food intake disorder. And then there's obviously the otherwise specified, where you have kind of the atypical symptoms. So they are symptoms of the above eating disorders, but they don't meet diagnostic criteria. So we'll go into detail about these with a focus primarily on bulimia and anorexia. So it's estimated that about 8 million Americans have some sort of eating disorder. And like many of the other disorders that we talk about, it's much more prevalent among women to men, about 7 million to 7 million to 1 million. It was previously thought that men didn't have eating disorders, but we are seeing now more and more, especially among men who engage in sports such as wrestling, or bodybuilding. We are seeing increased levels of, different types of eating disorders, such as anorexia and bulimia, as well as in the gay community where there's increased pressure for men to look a certain way. About 1 in every 200 American women suffers from anorexia, and 2 to 3 in every 100 women suffers from bulimia. So you can see that more women have bulimia than anorexia. Although, we talk about the eating disorders otherwise specified, I think that a lot of women engage in some of the behaviors of anorexia with the restricting at various points in their life, but don't meet diagnostic criteria. And as I mentioned, about half of us will personally know somebody who has a diagnosable eating disorder because these are relatively prevalent in our culture. So these are particularly prevalent in young girls and women between the ages of 13 to 18 in Western cultures. And that's kind of our period of development, figuring out who we are. And that's for young women, especially a period of time where there is a lot of emphasis on appearance. And so women are looking to role models, celebrities and magazines, and they're seeing women who are unrealistically thin. And so we'll talk about the etiology of it later on, but a lot of it is assumed because especially it's more prevalent in Western culture, that it has to do with the images that we're portraying in our culture. But as I mentioned, about 5 to 15% of those with anorexia, or bulimia, and about 35% of those with binge eating disorder are male. So males have been a long overlooked group in this kind of diagnosis. And so I think, we are seeing growing numbers of men being diagnosed with these disorders. And I think it's something that you kind of in the future are going to need to keep an eye out for. Generally, about 90% of cases of severe anorexia and bulimia come from upper social classes, and they're living in highly competitive environments. So you're seeing, whereas, with many other disorders, people tend to have difficulty functioning and as a consequence kind of lose out on opportunities to make income and might not be living very well. Those who suffer from these eating disorders actually are kind of in the upper class and I mean upper class socioeconomic status of society. So the higher prevalence in females is likely influenced by motivational state and different neural activity. So there's actually been some brain study that kind of has shown that there are differences in neural activity after exposure to high density foods in males and females after they've fasted or not fasted. They've done these kind of both in rats but also in human beings. And so these results suggest that women tend to exhibit greater activations in regions associated with cognition and affect in response to food cues when fasting. And so basically that means kind of in regular English that women are more susceptible to when they've been deprived to the rewarding consequences of food, and they tend to respond to them. A lot of people, especially I talk to a lot of people who have depression and anxiety, and they talk about food as a coping strategy, and you hear this a lot more for women than men, and food becomes reinforcing a lot for women. And so there are different neural activations and reactions in males and females. So that might in part explain the differences between women and men. In terms of prevalence, historically, the majority of people, especially with anorexia and bulimia, have been white. However, more recently, especially for binge eating disorder and anorexia, we're seeing more similar rates across different races and ethnicities. We are seeing higher rates of bulimia among Latinas and African Americans. And so this might be just because of cultural shifts and, differences in our population, people coming from various different countries. Unfortunately, because of a lot of the cultural biases that we have, and that this is kind of a white disorder, ethnic minorities are generally less likely to be diagnosed with an eating disorder as opposed and receive treatment for that as opposed to somebody who is white. And they found that among those who have diabetes, about 15% of those have some sort of eating disorder, especially among young people. And a lot of this could be kind of the binge eating disorder. So now, in terms of mortality, eating disorders have the highest mortality rate of any mental illness, with about 5 to 10% of people who have anorexia will die within 10 years after developing it. And about 18 to 20% of those with anorexia will be dead 20 years following, and about 30 to 40% ever fully recover. So this is a very serious disease. A lot of this happens either because they starve themselves to death, or there is some, they deplete themselves of the nutrients required. They have heart arrhythmias, things like that, because of their failing to feed themselves. The mortality rate associated with anorexia nervosa is 12 times higher than the death rate of all causes for females between the ages of 15 to 24. So that's pretty serious, and it's something that we have to take very seriously as a consequence. So basically, what these statistics are telling us is about 20% of people who have anorexia will die as a result. Before they should have died as a result from complications relating to their disorder, and that can include suicide and heart-related problems. So, as I mentioned, there are 5 feeding and eating disorders in the DSM. The first one is pica, which is eating non-nutritive, non-food substances for 1 month or more. And a rule out here, you'd want to rule out somebody who has mental retardation or a developmental delay, because that can be something else. But these are people who eat hair, who eat like dust balls. I've seen these on like those like TLC shows where people talk about the weird things that they eat, and this is what we would call pica. This would be a diagnosable eating disorder. Rumination disorder, unlike what the name suggests, is really regurgitation disorder. And basically, you have repeated regurgitation of food for at least a month. And this is like, I don't know if you're familiar with how cows eat their food, but they ingest the food, they regurgitate it, they chew it, which is now called cud, and then they'll swallow it again. And rumination disorder is something similar, but just in humans. Like they will eat the food, they will spit it up in their mouths generally. Generally, they chew it up and then swallow it again. Some people will spit it out, but generally it's kind of like the cud, and then they re-swallow it. And then avoidant or restrictive is the restriction of food intake, which is different, doesn't quite meet the diagnostic criteria of anorexia. They just kind of will not have any interest in taking food in. Now, the difference between these 3 disorders and some of the other ones that we're talking about is in the DSM-4, these were diagnosed as disorders first diagnosed in childhood, and these are most prevalent among young kids. Some of these will disappear as they age, but avoidant restricted, for example, would differentiate between anorexia because it would happen in a younger child who just would not want to eat. Then we have the ones that we're more familiar with, anorexia, bulimia, and binge eating disorder, which we'll go into. So bulimia nervosa. I mean, I guess it was before your time, but there was this one movie that I remember very vividly from my childhood with Meredith Baxter Birney, where she played a woman who had bulimia nervosa. She went into the fridge and they would show her binges where she was basically shoving everything into her face, including kind of like a cake that was for her son's birthday. And then she would go and throw it up. So a lot of people will say, we'll talk about, bulimia nervosa, but really these binges have to be kind of extreme. So it's recurrent episodes of binge eating, and this is more than just eating like a bag of chips. These are eating large periods of food, usually within a 2-hour period, and it's definitely larger than most people would eat during a similar period and under similar circumstances. So this is not just like kind of having, 4 slices of pizza. This is eating like 2 or 3 pies, and the eating is usually more rapid than when you're kind of like just you're sitting eating mindlessly on the couch and you've figured out you've eaten the entire bag of chips. So this is like a sense of lack of control. Like you're literally shoving food in your face. You're not really gaining any satisfaction of it. You feel like you have a lack of control over eating during these periods. So you cannot feel like you cannot stop yourself or control how much you're eating. And you have to have recurrent inappropriate compensatory behavior in order to prevent weight gain, such as vomiting, using laxatives, diuretics, enemas, or other medications, fasting, or excessive exercise. Again, probably before your time, but some of you probably have watched the old episodes of Beverly Hills 90210, but Kelly Taylor would do this, and then she would engage in exercise for like hours at a time. So that could also be the inappropriate compensatory behavior. We traditionally associate it with vomiting, but you can also abuse laxatives and do the exercise as well. The binge eating and inappropriate and compensatory behaviors have to occur on average at least once a week for 3 months. So you have to assess the frequency of it. If it happens less frequently, you would have to do like a not otherwise or otherwise specified disorder. There has to be a self-evaluation, which is influenced by body shape or weight. So you're doing this because you are concerned about the way that you're looking. And it doesn't occur exclusively during episodes of anorexia nervosa. What differentiates oftentimes people and like how we know diagnostically oftentimes somebody has bulimia is in addition to obviously having these symptoms, dentists know because the enamel on the teeth is worn down because of the acid that comes up with the regurgitation, or their bowels are completely messed up because they're abusing laxatives. The other thing that we notice as opposed to someone with anorexia nervosa is that generally people with bulimia are either average weight or slightly above average, because even if they throw up the food or they use laxatives afterwards, the body still digests a certain number of these foods, and they're often very high calorically, and so even if you're throwing everything up, the body still is digesting those, so you're still getting some calories there. So you know, again, here it's important to note that the 2 hour time frame is important, and you're kind of consuming over 1,000 calories, or something that's 3 times typically what a food portion would be for during that binge episode. People have been known to consume up to 20,000 calories in one particular binge. And really, the hallmark thing is this feeling out of control. Like you just are shoving food in your mouth. It's happening rapidly and you can't control it. So here's kind of to help you separate subjective overeating versus binge eating. And this is like important diagnostically because people will endorse binging, but when you kind of get at it, it's not quite there. So, a subjective large binge will be large, like, people may view it as excessive, like you just had 3 pieces of pizza, which may be kind of excessive, but it's not overly large. And you may feel like you have a loss of control, but objectively, you can stop if you really want to. People who have a binge have really, as we talked about, up to 20,000 calories or 3 times the normal amount of food and feel this loss of control. So it's really kind of this subjectivity that we're getting at here. So in terms of the epidemiology in the lifetime, about 2% of the population will have this diagnosis. It usually begins in adolescence and young adulthood. It's relatively uncommon to have the onset after 40. And as we talked about, females are much more likely to develop this disorder than males. As I mentioned, people are usually normal or overweight, and there is a higher mortality rate, but not as high as anorexia. And the higher mortality rate is often due to electrolyte imbalances that result as a consequence of the vomiting, because as you vomit, your electrolytes in your body become unbalanced. And if you remember from your biology 101, you have to have sodium and chloride that kind of go in through osmosis through your cells, and those become imbalanced, and your levels of water and all this stuff in your body becomes unbalanced, so people can have problems with their heart. Your potassium levels which you need to kind of keep your heart muscles going, become unbalanced. So all of that stuff might not work out very well. In terms of comorbidity, there are high levels of comorbidity with substance abuse, particularly alcoholism. People who have bulimia are 3 times more likely to also have alcoholism. You also see 2 times more likely to have phobias, depression, 8 times more likely to eventually develop anorexia, and we often see a high comorbidity among those with borderline personality disorder. So As I mentioned, here are some of the physical and psychological effects of bulimia. So as I mentioned, the electrolyte and fluid imbalance, and that's what the potential mortality is due from. They might develop gastric and esophageal irritation and bleeding, bowel abnormalities, swelling, urinary infections, parotid gland swelling, dental erosion, as we talked about, because the acid erodes the enamel, gingivitis, osteoporosis because of the electrolyte imbalance and the calcium being spit up, calluses on the knuckles because they sometimes stick their hands down their throats, renal failure or death, again, because you have to have the electrolytes in your kidneys, depression, low self-esteem, self-absorption. You'll see some ritualistic behaviors, so you have to kind of separate it out from OCD. Perfectionism, it's not as much perfectionism in bulimia as you'll see in anorexia, but there also is some perfectionism, self-consciousness, anxiety, substance abuse, irritability. You'll see, again, some of the criteria of bipolar disorder in terms of impulsive spending and shoplifting. So these are kind of differential diagnosis things that you want to kind of rule out when you're making this diagnosis. So binge eating disorder, also known as BED, very similar to bulimia, except that they are not throwing up afterwards. So it has to also happen once a week for 3 months, but they don't have any compensatory behaviors. So they have to eat more rapidly than usual. They eat until they feel uncomfortably full. They eat large amounts of food when not hungry. They eat alone because they're embarrassed. And they can feel disgusted or depressed or guilty after a binge. And you have to have 3 of those 5 criteria in order to meet criteria B. So this one begins a little bit later than some of the other, than anorexia. So we're seeing it kind of in late teens, early 20s. And we see it across the lifespan. It's more common than bulimia. And it's highly comorbid with obesity. As you can imagine, you're taking in large volumes of food and there are no compensatory behaviors, so you're digesting all of it. But all those who have obesity don't necessarily have binge eating disorder. It affects 2% of the population, and 8% of those among those who are obese have binge eating disorder. The differences between men and women are slightly less profound here. 3.5% of women and 2% of men meet the diagnostic criteria. And fewer than 50% of those who have this disorder kind of seek treatment for it, because I think if you go back to the kind of the feelings of guilt and shame, it's kind of there's a stigma associated with it, and I think they're hesitant to seek treatment. Right now, CBT seems like the best option. You generally measure kind of the binges and things like that. So there's been a lot of understanding in terms of binge eating disorder, but there's still a lot of unknowns because a lot of people aren't seeking treatment for this. We don't have a lot of information about it. It's kind of still to be determined. It seems like it's still somewhat different from the other eating disorders, including bulimia. A lot of the things that we thought about binge eating disorder, we kind of based on bulimia, but it seems like that might not be the case. So there are also similar to some of the other eating disorders, there are the sociocultural pressures, the ideal body internalization and body mass dissatisfaction, but you're not seeing the compensatory behaviors. And so we really still need to understand kind of a lot of the stuff regarding etiology, demographics, and, any racial and cultural differences among those who present with this disorder. And until the stigma is kind of lifted and people are seeking treatment a little bit more and presenting, I think we're not really able to fully understand this disorder, what causes it, and how to treat it most effectively. Anorexia nervosa, again, is an eating disorder. Most of you have probably heard of it. We generally call it anorexia. It's characterized by a refusal to maintain normal body weight, and you see a body mass index of 7, like normal is 20 to 25, so people with anorexia have to have under 17.5 or be below kind of 85% of normal weight. Plus, there is an intense fear of gaining weight or any kind of persistent behavior that interferes with weight gain, and there's a distorted sense of body shape. So even though, you see them looking like this, they look in the mirror and they see somebody who is overweight. They don't see somebody who is gaunt and skinny. So there are 2 types of anorexia. There's the restricting type, which is the one we most typically kind of think about, and that's when they lose weight by limiting the amount of food they consume. And so that way, For example, they're eating very little. You'll often see them eating diet drinks, eating carrots, which have very few calories, herbal teas, that, for example, but nothing that has any substantive nutritional value. Or there's the binge eating, binging purging type. So they engage in binges, followed by purging, but these are different than those with bulimia because these individuals usually have normal or below normal body weight because their compensatory behaviors are much more extreme and the binges are more rare. So some of the things that we see in terms of characteristics of those with anorexia is the low self-esteem and denial, shame, depression, social problems. There's a preoccupation with food, and I think that's in large part because they're not eating, so they become overly fixated on it. They think about, how many calories is in everything. Especially among those that are restricting types, we see people who are more introverted, shy, compulsive, stubborn, and perfectionism has been very strongly linked among those with anorexia and among those with anorexia. The people who have more binging type of anorexia have more interpersonal problems, family problems, and work issues. Anorexia is very strongly linked to depression, relationship problems, and suicide, largely because there's this constant focus on not being good enough in the shape of their body. I mean, this takes up, and I think in part because they're starving themselves, so you're biologically predisposed to think about food constantly, but that prohibits you from kind of actively participating in a relationship or and you can see how that would make somebody depressed and potentially suicidal. It's the most lethal of the disorders and has severe physical effects, including altered electrolyte levels like potassium and sodium, which impact nerve and muscle functioning. Also leads to these low body weights to low blood pressure, cardiac damage, osteoporosis, and infertility. So there's some similarities between anorexia and bulimia. Both start with intense dieting, which is why we have to be very careful, what we say to young women about body shape and about dieting. So, if you are a mother of a young girl or you have a young girl in your family, like never make comments about your own body weight because they internalize that. Like if they say that you're complaining about your body, then they may feel like they're not adequate enough. There's an intense fear of becoming fat. They have a distorted body image. They have anxiety and depression. There's both have a low self-esteem, generally interpersonal relationship problems. Given that people with bulimia tend to be a little bit older, that's more like romantic, versus those with anorexia, it tends to be family. And both are primarily affecting men as opposed to women. So if you see the the differences, so those with anorexia refuse to maintain normal body weight. They deny feelings of hunger. They have less antisocial behavior in the sense of less acting out behavior. They distrust others because oftentimes others want to give them food and therefore they want to stay away from others. They tend to be more obsessive. It usually happens at a younger age. They tend to deny family conflict, and there's usually a sexual inexperience. Among those with bulimia, we see a greater body dissatisfaction, intense hunger, more tendency to have antisocial behaviors and more kind of acting out, more trusting of others, more kind of drama prone. So that was remember we saw the comorbidity with the borderline personality disorder. The onset slightly later, kind of more in the late teens, early 20s, so emerging adulthood. There's exaggerated family conflict, so while there may be some, they often kind of misrepresented as being larger than it is. And there tend to be, again, that kind of goes on with the acting out behavior, more sexually experienced. So we talked a little bit about the sociocultural perspective, but generally what we in our Western culture associate thinness with attractiveness and also actually wealth, and that's partly why we see this in the upper SES. If you look, unlike, historically where, kind of in the 15th and 16th century where there was a lack of food, the royals were tend to be pleasantly plump, which suggested that they, had an abundance of food. These days, those people who are kind of the socialites and those who are kind of the wealthier want to be as thin as they possibly can, and you see higher levels of eating disorders among this population. And so we see in the media, both in print and online and, in fashion shows, that those who are said to be beautiful are thin. And so choice and availability of food increases vulnerability to eating disorders. intense dieting, and then low self-esteem and teasing about weight can also contribute to the onset of eating disorders. So what I think is interesting is that females have generally a more distorted view of their body. So if you see kind of what females view as attractive and ideal, it's much less than what men like. Like men like, a more curvaceous woman. Women tend to view a woman who is less curvy, if you kind of see, and women tend to be further than the ideal than the men. So if you look at men's ideal and men's current, they're very close together. So men tend to have, they tend to be more satisfied with their body than the women do. There's also, you can see here, if you compare the average size woman to a Barbie doll or a store mannequin, the average size woman doesn't compare. I mean, she's heavier, her proportions don't match up. And this is what we give to young girls to say this is the ideal of beauty. And this becomes somewhat internalized because that's what they're seeing all around them. Even if we explicitly don't say this is what we view as beautiful, this is what they're seeing and this is what they're internalizing. So in terms of the sociocultural model, so we have the exposure to the thin ideal. This ideal, whether it's explicit or implicit, becomes internalized. They experience the discrepancy between what they are and what they see, which results in body dissatisfaction. As a consequence, they start kind of with dietary restrictions, and then that can result in over or under eating. Which is then reinforced, and you end up with an eating disorder. So that's kind of the sociocultural perspective. In terms of genetic factors among anorexia, we do see that there is a higher concordance among monozygotic as opposed to dizygotic twins, which could suggest a genetic predisposition. However, this does not rule out familiar causes, but it does suggest a potential genetic predisposition. So it's estimated that for bulimia nervosa, there is about a 50 to 83% heredity, and for binge eating disorder, about 41%. Now, it's hard because a lot of these things are modeled behaviors, and so, if a mother is restricting her food intake, this may then be, transferred down to the child. Serotonin also may play a role, and that's why you see a lot of the comorbidity with depression. We find low levels of serotonin associated with eating disorders, particularly bulimia. And it may be directly related to the craving for food high in carbohydrates, which once you eat those foods, you get a release of serotonin and kind of like that feeling. But we also see serotonin in OCD and depression, so it's really hard to kind of tease a lot of this stuff apart. So, we think it's involved, and, taking antidepressants, especially those for bulimia, does help somewhat. So it's thought that maybe, that's kind of associated. We're actually seeing higher levels of serotonin among those with anorexia, and higher levels of serotonin produce feelings of satiation, which may inhibit eating behavior among those with anorexia. Now, oftentimes these are done after the people are diagnosed, so we don't know if the disorders are causing these imbalances or these are premorbid, for example. We're also seeing issues with dopamine functioning, and that's related to the reward sensitivity, and these are different with people with eating disorders. So we have those with binge eating disorder with the hyper response to reward, which results in the overconsumption. And those with bulimia nervosa, where they have lower levels of dopamine transmission. So we do think that there are biochemical markers, but it's really hard, as I mentioned, to kind of tease apart what is causal and what is a result of the actual eating disorder. So kind of in the socio-cognitive model, cognitive behavioral theories and affect regulation models suggest that these distorted cognitions are the kind of the causal factor, and these happened in childhood because of these internalized, images that we have, as well as because of what our parents and the things that are being modeled around us. And these restrictive behaviors are then maintained because there's a focus on food and sensitivity to food cues that result from deprivation. And then binging can be maintained because it reduces the negative affect present before the binge. And so, people feel bad, then they get reinforced and they feel bad after. And so then they compensate for feeling bad by binging more. So some of the cognitive distortions that we see among those with bulimia nervosa is the feelings of uncontrollability, which is one of the diagnostic criteria. I'm never going to be able to stop if I have that piece of candy. Um, Buying a whole bag of bagels is not that big a deal. It's not going to hurt. Eating the pizza will make me feel much better. I'm going to gain a ton of weight. And then their thought processes that we kind of see, especially among those with anorexia nervosa, tend to be very rigid and obsessional, and it's very hard to change. What I've seen is that those with very low body weights, their cognitive functioning decreases to the point where it becomes super obsessive and focused on foods, and therapy doesn't work until they kind of get in more of a normal body range, because I think when you are starving yourself, your brain doesn't have that much energy. And so the focus can only be on getting that much food. And so once your body has the food, then you can focus on kind of other things and working on the treatment. So treatment for anorexia primarily involves feeding somebody first. Family dynamics are thought to play a large part in the onset of eating disorders. Munchen was one of the kind of pioneers in this area, and he talked about the enmeshed family, where everybody is kind of, into everybody else's business, and so they cause this intertwining or enmeshment, or clinging and interdependence among the family members. And there seems to be like an overlapping identity, so it's hard to see where the mother ends and the child begins. They might also be overprotective and avoid family conflict, so turning a blind eye. So if there are problems, they don't discuss it, but rather they kind of pretend they don't exist. So dysfunctional family systems may lead to difficulties with individuation during adolescence, which then is thought to be a causal factor for anorexia nervosa, although we do also see higher degrees of parental conflict and oftentimes divorce among those with anorexia. And the kids kind of feel like their lives are out of control, and this is one thing they can control. But there's not a lot of support necessarily for this perspective of anorexia nervosa, but we do find that family-based treatments do work best for those with anorexia, typically because the individuals tend to be younger, and family interventions work best for younger kids as opposed to working individually with them. DSM tried to address a dimensional approach, as we talked about, kind of at the beginning of this course, with these eating disorders. So anorexia, they base the severity of the disorder on body mass functioning. And then bulimia, the severity of the disorder is based on the frequency of inappropriate compensatory behaviors. For binge eating disorder, the severity is based on the frequency of the binges. And what they haven't included yet, but kind of should be included in future, and probably some of the stuff they're still investigating, is some of the symptoms, sociocultural influences, like how society and culture is influencing the diagnosis, comorbidity, and the neurobiology. So these are things that we still need to find out about. I think we're still relatively in the naissance with a lot of the stuff. In terms of treatment, most people with bulimia don't get mental health treatment, but what we do know is CBT and antidepressants can be helpful, and about 50% of those with bulimia stop on their own without treatment eventually. So this kind of peaks in kind of in emerging adulthood and will die off eventually. Among those with binge eating disorder, we see CBT, interpersonal therapy, dialectical behavior therapy works well. Also, weight loss may be a target if the individual is obese, so you want to be doing, monitoring of these binges and what's causing the binges. And about 70 to 85% of those with binge eating disorder will stop without treatment. For anorexia, family-based therapy is recommended, as for the reasons that I mentioned earlier. We don't really know exactly what works other than hospitalization and forced food intake. There's really no gold standard. A lot of people with severe anorexia have to be hospitalized against their will and put in inpatient programs until they gain the weight. And even then, after that, the weight gain is incredibly traumatic for them. And so a lot of those with anorexia never will eat normally ever in their life. It may be better so that they don't risk death, but they will always have some